All right, all right. Here we go. Welcome, everybody. I know it's an hour earlier than normal, so thanks so much for showing up. We are a couple minutes after 4, so I'm going to make this short and sweet. If y'all have never been on a CE webinar before, there's something you have to do. It's called stay on the whole time. We can't see your face, but we can see if you're on. So we'd love for you to stay on the whole time. If you'd like to get a CE for it, at the end, a couple hours after the webinar, you guys are going to get an email. If you don't have an email in your inbox, it's in your spam. Click the link, spend 14 seconds checking boxes, clicking OK, and you'll get 1 CE for tonight. But that's not really why you're here, is my guess. You are here for this guy, Dr. Harmandip, or Aman, as our friends call him, Singh. He's going to talk to you about sleep reports and really what's behind those tonight. I'm sure most of you on here have already seen sleep study reports. You've run your own. You've seen ones that sleep doctors have run. That's really why you're here. So let me give you a couple of directions. One, if you've been on our webinars before, you know that you can ask tech questions and all of that kind of stuff in the chat. If you're having issues, let us know in the chat. If you have any questions for Dr. Singh, please ask those in the Q&A. Both are turned on. So please ask your tech issue questions in the chat. If you have questions for Dr. Singh, please ask those in the Q&A. Also, if he asks you questions, please also respond in the chat. You guys know how this works. You didn't come to see me. You came to see him. So let me introduce him. This is probably the most informal introduction you're going to ever get, Dr. Singh. But I knew this guy 14 years ago. No, 16. I can't do math very well. How long has it been since you became a sleep doctor?
Yes, I think we met like 17, 18 years ago, right?
Okay. So we had lunch right as he took his boards, and he's been doing amazing things ever since. Dr. Singh owns iSleep Physicians. Many of you know him because he does telemedicine consults and in sleep study interpretations. He's got a bunch of providers under him working alongside of him on his team. This guy knows his stuff. And he also works a lot with dentists like you all. So he knows everything about the channels in the sleep studies, on the sleep reports. His job tonight is to translate that technical jargon and nonsense, not really nonsense, into plain terms. So without further ado, Aman, will you please take it away? Show these guys what you've got tonight.
We'll do. Thank you, Michael. And thank you for that informal introduction, actually. And that's actually the way I function, right? So I want to keep it very informal. It's been great working with the Awaken to Sleep crew for the last few years. We've gotten to know each other even more, reacquainted. So, it's my pleasure to be here today and to, really make it informal. You guys have any questions, put them in the chat. Interrupt me if you have to, if I keep blabbing away. So my goal is to share with you my understanding of sleep testing and really to go beyond the AHI, right? Because a lot of times we kind of get stuck there, but sleep test can show us more than just the AHI. Although we know that's an important parameter, obviously that's what we're trying to do in terms of treating sleep apnea, and that's why we're all here. But you got to look beyond that in terms of some nuances and clinical situations that can pop up, even in terms of efficacy and seeing where you are in terms of therapy, right? So those are the kind of things you really want to keep your eyes and ears open to. And me as a provider, I'm always here to answer your questions or work with you. That's where I really get my satisfaction out of, and working with providers and seeing patients really respond great in terms of their therapy. And just a little bit of more about my background. I'm actually a board certified psychiatry. One of the reasons I shifted to sleep was because I saw a lot of folks that just were struggling with sleep issues, as many of us are in the world, and really not getting detected, right? And then finally, when I started doing that, I saw a real shift in their lives and their functioning and their symptoms, psychiatrically and medically. And that's where I was like, you know what, I'm going to go get a fellowship, and take my boards and meet Michael, and and here we are. So, all right, so let's move forward in terms of, I think it's really important to understand first of what is a polysomnogram, because we call that our gold standard, right? It's a type 1 test when it comes to insurance terms, but what are we measuring when it comes to you taking yourself or a patient doing a lab study, right? So we're measuring O2, oxygen saturations with pulse oximetry, measuring brain waves with the EEG, EOG, extraocular movements, which helps us identify REM sleep, airflow in terms of nasal pressure transducer, right? So your nasal airflow, but also oral airflow. If you have trouble breathing your nose, we're going to detect it through an oral thermistor, right? And then EMG in terms of your uh, muscles in terms of when they're relaxed, when they're clenched, for example, or bruxism. We can see that with an EMG because those are attached to your mandible and your chin, right? Microphone, snoring, of course, the biggest symptom that leads most people getting a sleep test on. ECG, of course, heart rate in terms of seeing heart rate variability, any arrhythmias that are present, which we know are common with some of these folks. And of course, respiratory effort, which comes with a thoracic belt and abdominal belt, which helps us to see, like, are we making an effort to breathe or are we not, helping us identify central versus obstructive sleep apneas, and also seeing paradoxical breathing when it comes to having obstruction in your airway when they start working against each other. And then, of course, position is important, obviously, in terms of when you're on your back, when you're on your side, when you're prone, and those are important parameters in terms of seeing, when the apnea gets worse, if it's only present on your back, that sort of thing, right? So, this is what we're measuring, and historically the issue has been a lot of folks is that they don't want to come in a lab and get all these wires on them, and this is what we see, when you do that, right? So if you look at this is a 60-second view of a patient in REM sleep, you can see rapid eye movements here. And then you can see patients also having this flat lining, which we look at here in terms of flow. And, that's where we look at and detect an apnea from. And then there's still effort to breathe, as you can see, but you can see also the thorax and the abdomen start working against each other here. So this is a typical apnea, and you can see here the desaturation right down to 65%. So it's this, this apnea here almost is 30 seconds long. It results in arousal. You can see the red circle there up at top, which is the patient waking up briefly. Okay, so that is typical of what we're measuring in a lab study, and the EEG helps us to identify different stages of sleep. Of course, delta, theta, and alpha, stage 1, 2, and 3, and of course variable stages like we see in REM sleep with sawtooth waves, and like I mentioned, the paradoxical breathing as well. So, it's extensive and gives us a lot of information, and that's why we think of it as a gold standard. This is a hypnogram, right? So this can actually just show you the entire night with one view. And you can see all the different parameters that are being measured here, stages of sleep at top, down to the desaturations down below, and the position, as well as apneas, arousals. And you can see those large, significant desaturations, in those blue, in the blue measure there, the blue line there, where you see where they're going down to like 60s, 70s. And again, as a result of having apnea, and you can see some of it's related to REM sleep too. So it's a great way of just looking at the entire night and getting an idea of what's happening with the patient the entire night. Where are they really having trouble? At what points of the night? What stages of sleep? What position? That sort of thing, right? Normal sleep efficiency is 85%, but we know a lot of our folks wake up a lot. They don't get that normal sleep efficiency, whether they know it or not, because the apnea is actually waking them up, and as a result, they don't get consolidated sleep. They don't even get into the deep stages of sleep. And this is another depiction here of like a patient that's untreated. That's another classic thing with the polysomnogram, is that we can see arousals, we can see when they're waking up, and they're not getting those deeper stages of sleep. And then you can look down below, where's a treated patient. So a patient that has significant sleep apnea, now we treat them, you can see they're waking up a lot less. They're actually getting into those deeper stages of sleep, getting stage 3 sleep, getting REM sleep a lot more than they would be if they're untreated, right? And the arousal index starts to decrease too as we treat sleep apnea. And then, that's when our patients will feel more restored, more rested, and of course, then more alert and awake during the day. So yeah, so let's shift now, right? So that's our gold standard. That's always what we've done. When I came into practice here, uh, 17 years ago, we know that it was easy to get that type 1 study done. And we know now it's nearly impossible. You really got to struggle to get that authorized, unless you're having some other indication for getting it done, which we'll talk about down the line. Now in today's day and age, home sleep testing is what has taken over. Okay. So, in terms of home sleep testing, and I'll show you these next few slides, but the way insurance likes to categorize home sleep testing is it a type 2, right? So where you're actually taking a kid home, you're putting it on, you are actually getting a respiratory effort, you're actually measuring an EEG, right? So you may have leads on your forehead. Um, and so you have 7 parameters at least. Um, and so it's pretty extensive in terms of relating to the PSG, to the type 1, or is there type 3 where you have 4 parameters, mainly oxygen saturation, heart, effort, and airflow, right? So those are your apnea links, your allisonite ones, they're type 3s, and type 4, of course, which we really don't do because it's pretty much measuring your O2 DSATs and your heart, right? And so we can't really make a diagnosis off of that, but it can give us an idea if you're having significant desaturations. Okay, so we have, then we have now an entire different category of home sleep testing, right? What we categorize, what we don't even put in these categories, right? So 95800, which might use cardiopulmonary coupling, right? So like the sleep image test, right? Or does it use PAT technology, right? So we're measuring arterial tone, right? Like the watch PAT. Um, we even have Sunrise now, which measures mandibular movement, right? So there's a lot of different options out there now. Sympathetic tone in terms of the belung ring, right? So there's options there now that can't even be put in a category. So my point in telling you that is that there are a significant number of options out there, and I'm not here to really talk about what's the best option. That's something that we can have a discussion at another point. I'm here to really talk about the fact that we have these devices now, and what can we learn from them when it comes to reading the report and understanding it clinically, right? And so these next few slides are just going to show you the variety of options you have, right? So Z machine, sleep profiler, which are type 2s. You get the MediBite, the AccuSom, the ApniTrack, the Sleep View, the Nox T3. So we're getting now into more the type 3s, uh, the Embleta, right? And then we get into the newer ones, right? Like the Night Owl, which uses PAT, sleep image, and we have the Aries too, which can measure EEGs, and of course the WatchPat, which uses arterial tone as well, and now is kind of the point where it can pick up central apneas, which a lot of these other devices can as well. Including the Wesper device, which is a unique device on its own. So there are a lot of devices out there now, and when it comes down to it, we're trying to identify, number one, the type of sleep apnea you have. We know the large majority of folks out there have obstructive sleep apnea, right? So they have obstruction of their airway. And as a result, they have symptomatology like snoring. We know patients do have central sleep apnea. Maybe maybe they're taking opiates. Maybe it's secondary to obstructive sleep apnea. Maybe they have cardiological or neurological issues that's causing that, right? So central apnea is important to try to pick up if you can. It's not common, of course, but if a patient has it, that's going to alter uh, our treatment in terms of what we're looking for, especially if it's severe and it's primary. And then mixed complex sleep apnea, often we'll see with patients, they may have it at baseline, but some of them we see when they start on CPAP, they actually get induced. They get central apneas that are induced as a result of CPAP. And, sometimes they can't tolerate the CPAP. They may need ASV, BiPAP ST, or maybe if it's CPAP causing it, right, then you got to think about something else to treat them, like oral appliance therapy. If the obstructive sleep apnea still is the primary diagnosis. So important to understand these things. It's important for us to tell you that information related to you in terms of what's going on with these patients. And so you have a better idea in terms of, hey, what am I supposed to do with this patient, right? Am I supposed to really send him back for a lab titration study if they have primary central sleep apnea? Or is the central sleep apnea minimal or mild and it's really secondary to the obstructive? And can I treat the obstructive? right, with an oral appliance, and then see if the central apnea goes away, which a lot of times it does. So these are important things to understand. Um, bottom line is when you look at the data, when you look at sort of how do we come up with this staging in terms of severity, right? What's mild, what's moderate, what's severe, right? And so if you look back, it really goes back to looking at data and looking at CMS actually coming up with, hey, you know what, these patients are going to be diagnosed with mild. Do they have an AHI 5 to 15? Then they're mild. 15 to 30, moderate, greater than 30, severe. But this sort of gives you an idea in terms of continuum on the level of obstruction of sleep disordered breathing, right? So if you look at the number of people that just snore out there, 90 million. Okay. That's 1/3 of the population. And in fact, I would say it's probably a lot higher now. And this data is a little bit old, right? So that's occasional snoring. Regular snoring, of course, decreases, but this is the bulk of our folks out there. But it's important to identify them because, yes, a lot of them do have uh, sleep apnea and, upper airway resistance syndrome, right? Your AHI is less than 5, and we'll talk about this, but your RDI, maybe you're having respiratory effort related arousals, right? You're struggling to breathe, and it's not that you're desatting, but you're actually waking your brain up a lot, and you're not getting good consolidated sleep and poor quality sleep, non-restorative sleep, and that's something we've always called upper airway resistance syndrome. And let's talk about that in terms of the AHI and the RDI, right? Because
Hey, Dr. Singh,
yeah,
I hate to, I don't want
oh
to
no,
derail you here.
oh
I
no,
do
sure,
want to just a quick pause for a question that I
yeah,
know is,
absolutely,
we had this asked before the webinar. So
yeah,
there's a lot of folks that are in general dentistry, they're screening patients, they're their first contact. It's
yeah,
very different if they're having a patient referred in, obviously, that's been diagnosed. But if they're the first contact, what would be the exclusion criteria that you would say from a medical standpoint? These are the folks not to do a home test on that need to be seen for an in-lab test. I know most go to
yeah,
a home test, but just if you can give us some of the clinical parameters that as a sleep doctor, you would say,
yeah,
I'm not
yeah.
going to home test this person. They're going into straight into a lab because
Yeah, great
what would be
question,
those
actually.
things?
Great question. I'm going to actually forward my slides because here's your answer, right? So if you have someone that has significant cardiac factors, right? Like, do they have COPD or another hypoxic condition that requires supplemental oxygen, right? We don't want to really do those folks. We don't want to do HSTs on those folks. We'd prefer them do a lab study. Okay. Anyone that has like recent stroke, seizures, we want to do a lab study. Anyone that has active neuromuscular disease or congestive heart failure, right? Because they're going to have a hard time with their respiratory effort. So they may have a significant elevation in their CO2. We really want to be able to see that in a lab study. And so those folks are pretty much exclusionary. Also, then you can think about people that have parasomnias like, extensive REM behavior disorder, maybe they have dementia or Parkinson's. They need a caregiver, right? You're not going to be able to put on an HST. Even the caregiver might have a hard time helping them set up an HST, and they really need to have a tech on board and be monitored very carefully, right? So
Yeah.
those are other patients you got to think about. Um, so generally speaking, that's where you really want to start thinking about, okay, you really need to be in the lab. Um, Obviously, they're the minority of patients that we see.
Yeah.
Sometimes we'll have patients that have, uh, you know, so that's where I would say, like, when you guys run into them as dental providers, that's where you want to rule out doing an HST, right? Sometimes when we see them as sleep providers, we know patients may have like narcolepsy or risk for hypersomnia, or if maybe they have a negative HST and they're still at high risk for having um, sleep apnea. We're going to want to get an in lab study. But that's where I would say, anyone that has sort of the first few conditions I mentioned, you definitely want to kind of rule out an HST and move forward with an in lab study. Does that help, or anything else I can answer to that?
Yeah, it's just my bad. That was the a slide that's way ahead.
Oh
So
yeah,
I
yeah,
apologize for asking a question out of order, man.
no, all good, all
By
good.
all means, bring us back to home.
Yeah,
Thank
yeah,
you.
yeah. No, all good, all good. Yeah. No, it's important. It's an important question though, because there's not a lot of things out there that really exclude an HST. So that's one thing to be aware of. But those are the things that you want to be aware of course. Um, so when it comes to making the diagnosis, right, some of the things that obviously the HI, like I mentioned, but the RDI, I've always gotten questions from some of my dental colleagues like, okay, well, what do we look at, the HI or the RDI? And long story short, the RDI has helped us to be able to like recognize those folks that don't get a lot of oxygen desaturations, right? So maybe their AHI is normal, but the RDI is elevated because that includes what I mentioned earlier, those respiratory effort related arousals. Okay, so now you're struggling to breathe, your oxygen's not desatting, but you are waking up a lot, right? So that's still affecting your sleep. So you're not going to get restorative sleep out of it. So bottom line is the RDI can be very useful. And in the past, we would think of those folks as having upper airway resistance syndrome. Okay. A very common question I still get asked is like, okay, well, does my patient have UARS? Well, my answer to that is like, listen, if their AHI is normal, but the RDI is elevated, yeah, they do. Now, the American Academy of Sleep Medicine has made it very clear that those patients actually have OSA, right? But I know it's a term that is important for our dental colleagues to understand what's happening. So we'll still make that diagnosis too on our sleep testing, then, and those are patients that you should absolutely consider in terms of therapy, right? It's very important to identify those folks because a lot of times they get missed. And because they're not getting restorative sleep, because they're waking up a lot, we want to identify those folks and move forward with treatment. And oral appliance therapy can be extremely effective for those folks compared to CPAP, where a lot of times CPAP will actually maybe wake them up a lot more. So, that's really one important clinical vignette that I would say is that patients that have UARS, you know, for me at least, seeing this in practice, that using oral appliance therapy is way more beneficial than using CPAP. So again, we get back to the degree of severity and then making that diagnosis mild, moderate to severe, which is the system that we've had in place. I think this is going to change over the next 5 years, honestly. We're going to come up with better ways of really being able to discern severity. Okay. But this is what we have for now, and this is what our payers and our insurance companies dictate, right? And one other thing I'll just mention in terms of RDI, there's some payers like Medicare that are not going to recognize it. Okay. So you might have a patient that does have UARS, but guess what? Medicare is going to say, well, we're not going to provide therapy for this patient because they don't recognize the RDI, right? Which is unfortunate because there are your specialty groups like the American Academy of Sleep Medicine recognize, and we know it's an important clinical distinction. So why can't we treat those folks? And why can't the payers actually see the benefit of treating them, right? And this is the world we live in, unfortunately. But I always urge my dental colleagues to move forward, and have your patient really understand the clinical impact, right, of having that over the long run, because it's going to impact them in terms of comorbidities, right? It's still going to increase their risk for having high blood pressure, heart attacks, strokes, depression, dementia. Now we know in the long run, right, over time. And pediatrics, of course, our distinctions are different in terms of mild, moderate to severe, right? And so the more and more data we're getting with pediatrics, 1 to 5 being mild, 5 to 10 being moderate, and greater than 10 being severe is an important distinction to make as well, because with pediatrics, we can identify it when they're young, and I've seen this. You can really make a big impact in terms of their development and long-term outcomes. All right, so let's look particularly here at different studies, okay? And again, like you're going to see different types of studies here, and I'm not again talking about one particular device over another. My goal here is to look at, have you guys look at the clinical presentation here and really try to understand it, right? So here's a patient that's not diagnosed with sleep apnea, okay? They have a negative study here, but if you want to look at their sleep efficiency, it's pretty good, right? So we got a lot of sleep here on the night, but their diagnosis is negative for sleep apnea. Their O2 sats are pretty stable, except here we see the nadir is 87%, if you can see that highlighted part down low. And here you see their ODI is 5.2 events per hour, okay? So why am I bringing this up, right? Because here's where a patient that may have significant UARS mild sleep apnea often gets missed, right? Because now their AHI, their RDI is normal, but their ODI, their oxygen desaturation index, is actually elevated. So this particular situation, if you brought this to me, of course, I'd get more clinical history on this patient, but I would say for sure you should have a lab study, okay? Because this is the type of patient that is missed. And, because we see that their oxygen desaturation index, which tells you how many times an hour that their O2 sats are falling at least 3%, is elevated, that their chances of having mild sleep apnea are pretty high. Okay, so here's a patient that I would say we want to get a lab study done with a negative HST. What about positional OSA? This is often missed, right? And again, another important thing to look at is how much time is your patient spending in the supine position, right? So here we see 12% of the total sleep time was spent in the time of supine position. And when they are supine, index is 5.6. Okay. So this patient, if they spent more time supine, actually we would see their overall AHI would be higher. Okay. And that's why it's so important for patients to get supine sleep, right? Because this patient likely has positional sleep apnea. In fact, we can diagnose it just based on the fact that their supine AHI is 5.6. Okay. And we know for sure the data is very clear on that. The American Academy of Sleep Medicine, the American Academy of Dental Sleep Medicine very clearly say that oral appliance therapy, is first line for these folks that have positional sleep apnea. Okay, yeah, we can try positional treatment too, which exists, and there are a variety of different treatments now, right? In terms of trying to keep people off their back. We know the good old tennis ball trick doesn't work well, right? Sewing that tennis ball on the back of your t-shirt, the data shows it doesn't work well. They rip it off. So look at these sort of little details when you get the sleep test. And even for efficacy, by the way, if a patient's on oral appliance therapy, right? Let's say they're still struggling. They tell you, I feel a little bit better, but it's not that great. Look at their positional AHI, right? They're probably still having significant positional sleep apnea, which means that we want to proceed forward with further advancement, and modification of the oral appliance therapy, as much as we can until we, but often that's missed, and that's my point. We want to be really cognitive of positional sleep, and you want to utilize a test that's able to give you that sort of parameter. What about mild OSA? Okay, so in this particular case, I just wanted to highlight. So, 4% desaturation. So this is another caveat here we have in our industry, right? Unfortunately, payers, Medicare, want to use the 4% desaturation rule, right? Even though American Academy of Sleep Medicine says standard of care is by 3% desaturation, right? So what does that really mean? So what that means is, hey, what's your baseline O2 sats, right? When you're awake and you're falling asleep and you're not having any events, is it 97%? Okay, well, guess what? If you desat to 94% with an event, let's say you have a hypopnea, you desat to 94%. Well, that qualifies as a hypopnea because you desat at least 3%. Okay. Now, Medicare says, no, we're not going to qualify that event as a hypopnea. You got to desat to 93%, okay, to be able to qualify as having a hypopnea there. So what does that do? As you can see here, your 4% AHI is 2, okay? Your 3% is 6, okay? But this is where I always, and if you look at the sleep quality here, right, it's actually good. And the RDI down here, if you look, is 8, okay? They're desatting down to 91% with the baseline at 98%, okay? But here's where your clinical, the clinical skills got to step in, right? How do you feel during the day? Are you tired? Are you not restored? Are you having headaches? Are you having trouble focusing? Are you irritable, right? These sort of things. And, that's where I always tell my dental colleagues, like, yeah, use the screening questionnaires, but, at some point when you get the sleep test result back, yeah, you can refer to a sleep specialist. But if you have data there that shows the patient struggling during the day, that's a sign that really they need treatment. Okay. So in this particular case, look at your patient and say, how are you doing during the day or after you wake up in the morning? And then let's move forward with treatment. If you're struggling because you're 3% AHI, 6 means you have mild sleep apnea. Okay. And this is probably a younger patient. This is the other thing I wanted to clarify here, because you see the quality is good, not having a lot of fragmentation. Well, a lot of younger folks will have that ability to actually sleep through their apnea, I should say, or have decent quality sleep. It really starts to hit them when they get older. Okay. But the idea here is that, like if you're, and I can tell you an example I just saw the other day, 23-year-old, similar situation, like, yeah, I just feel a little bit groggy once in a while, not too bad. Snoring is out of the roof, of course. That's where his girlfriend told him to get the test done, right? Okay. But the biggest thing for me was that the guy's already got high blood pressure at age 23. Okay. So what does that mean? Well, that is hand in hand with sleep apnea, right? So I want to think about that and think, okay, what can I do to help prevent your blood pressure from getting worse, prevent you from, having a risk of having an MI, or arrhythmias in the future, and that sort of thing. And so look at the picture clinically. Really important, these mild OSA examples. Here's an Alice, sorry, no, here's an apnea link, 5.4 is your AHI, desetting down to 88%. And so this is someone that, if you look here in terms of uh, their time supine, it's all on their back, right? So again, another one with positional sleep apnea. So yeah, we can try to treat it positionally, not always successful, but if it works, great. If it doesn't, oral appliance therapy, number one option. Best thing for them in terms of data as well as clinically panning out for them. This is a watchpad example, a patient with an RDI here of 13. You see the AHI is normal. Okay, so in this particular case, they're getting a total sleep time of 7 hours. They're getting enough sleep. One of the things I wanted to point out here, there's no supine sleep, right? So what does that tell you? Well, if they slept on their back, the likelihood of their AHI and their RDI being higher is very high, right? But they didn't sleep on their back. So those are the kind of things that we got to recognize and say, hey, the patient really, this probably is an underestimation in terms of their degree of sleep disordered breathing. The other thing to point out here is they're desatting down. It's only one real quick desat, but that sometimes can be a sign in terms of if they had slept more time on their back, they might have further desaturation. With a minimum here of 90%, that's probably again underestimated because they didn't sleep any time on their back. But here's a patient where with the RDI being elevated, we would diagnose with UARS, right? And the other thing I should mention, by the way, is that now with ENSA data and being able to actually extrapolate total sleep time, we're seeing a lot more of this, right? So we can actually get a parameter for RDI based on that. And sometimes you're going to see these UARS examples pop up a lot more in your practice, especially with awaken to sleep, because that is the technology that's being utilized nowadays, which, it's fabulous, right? We've got a technology that can extrapolate from a type 3 test and extrapolate total sleep time and arousals and be able to see like where a patient's actually having respiratory effort related arousals versus frank apneas or hypopneas.
Oh. Where was that 15 years ago? Right?
Right.
I mean,
exactly.
But you know what? It's here today on every study. So that's a good thing.
Yeah,
Yeah.
absolutely. Absolutely. 100%. I love the fact that you guys are using them because it's a great technology and it really makes it's a game changer, right? For a lot of our patients that would have been missed. Here's a patient mild to moderate, like the point I wanted to make here is that AHI is 9.4. So do they have mild sleep apnea? Well, look at the RDI here. It's 19.7. Okay. So if you look at the RDI, they're going into moderate range, right? So mild to moderate. And so a lot of payers, honestly, will actually look at that and you can make the diagnosis of mild to moderate sleep apnea. And, they're more likely to pay for therapies like oral appliance therapy if you're able to see that and make that diagnosis. And again, that's what our job is to do, is to look at that data and tell you guys, hey, this is what's happening with your patient, right? We want to be able to make it very clear for you. Here, the maximum heart rate here is 127, right? My point in saying this is that is this artifact? It could be, but you'll see that sometimes these folks that have home sleep tests, sometimes you'll see, uh, wow, is my patient really getting up there? You know, the 120s and the 130s? And the answer is yes, they can, right? And we see that often with sleep disordered breathing. So if you see that sort of thing, you know, the question there is, you know, is it really underestimating the degree of sleep disordered breathing here and the impact, right? And sometimes we want to be able to point that out to our patients, like, hey, listen, your heart rate's getting up there at night, and that puts you at higher risk, of course, for other comorbidities. Here's moderate OSA examples. Same sort of thing here. You have an AHI of 22, 3%, you know, 4% to the mild range. Um, Now, you know, depending on who we're working with, you know, if someone wants is seeing Medicare patients, we're obviously going to make the diagnosis here in the 4% range. But generally speaking, we're going to go by the 3% rule. And if a patient's having significant apnea based on that, and you can see here they're having a lot more fragmentation, poor sleep quality as a result of getting the moderate range. Um, DSAT's down to 82%. You know, you can see the significant DSATs here on the hypnogram. You know, in terms of the sleep image, you see a lot in terms of unstable versus stable sleep. You know, stable is a nice blue, dark blue peaks you see up top, and then a lot more unstable sleep down below. Um, and so that helps to identify the poor sleep quality that these folks are really going through, the higher amount of OSA that they're having, the higher degree. Here's some more in terms of watch pat you're seeing. You know, again, RDI and AHI here 23.9, 24.6, right? So we are seeing the moderate range, and they're descending a lot worse here at 81% being the nadir, with the mean at 92%, right? And so that, you know, the point here is to like really get a better clinical picture in terms of the greater degree of apnea you have, the more likely you're going to have uh, a lower oxygen nadir, the more likely you have lower oxygen means, and the more likely you're going to have poor quality sleep, right? So the symptomatology usually pans out with that. Not always, though. And that's one important thing is that, you know, sometimes you'll have folks that come to you and tell you, like, hey, you know what? I don't really feel anything. A lot of times they're truck drivers, okay, trying to keep their job. Um, but the bottom line is that you got to ask about clinically what's going on with these patients. And sometimes even like things like caffeine, right? They're drinking a lot of caffeine to keep themselves awake during the day. This is a belong ring. This is comparing sympathetic tone and making the assessment using that. In this particular case, you see moderate sleep apnea with a BHI of 26.8. Uh, Sleep efficiency is fairly good, but a little bit reduced. Minimum O2 sat of 84%. Here's an arrhythmia ratio. So the thing about this ring is that it really is able to detect based on your heart variation if you're at higher risk for having an arrhythmia. So this particular case, it points that out, right? So another thing you could point out to your patients is that, hey, look, we're already seeing the signs here in your sleep, and this is something we want to be aware of and obviously get you treated so that it decreases your risk for having a sustained arrhythmia over time. Here's another example of moderate OSA. Same thing, AHI of 23, RDI is 25. Sleep efficiency is a little bit low here. And a lot of our folks have a trouble with sleep efficiency, like I mentioned earlier, right? They're waking up a lot during the night. Sometimes they wake up and they have a hard time getting back to sleep. Sometimes they even get diagnosed with insomnia, right? Which is an important thing to understand is that if you have a patient with significant sleep apnea, but they're talking to you about like not being able to fall asleep, waking up at night, having a hard time going back to sleep, we really want to treat the sleep apnea first, right? So a lot of dental colleagues will say, well, you know, should we put them on a sleep aid? Should they take melatonin? And I tell them, like, listen, first thing first, treat the sleep apnea. A lot of times you'll find these folks get better once we treat their sleep apnea. All right, so here's an example with artifact. You know, see a lot of O2 artifact here. You can see sustained O2 DSATs, right? And they're sustained, and you can see, generally speaking, you know, when we see with events, there's usually a quick DSAT, and then they come back to normal. It's sustained there. You can see a lot of a heart rate artifact here where the looks like even the device has fallen off or it's not detecting the heart rate. So that's the important thing here, is to really get an idea of like when sometimes you'll see a patient, oh my God, they're like mild sleep apnea, but they're desatting into the 60s. That's their nadir, but is it an artifact, right? And again, it's our job to point that out, uh, which 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 is good, because then you'll be understanding like, no, that's not the case. It's artifact. There's a night owl, moderate to severe OSA patient that's got their AHI hairs. So this is a multiple nights, right? So 2 nights, one night's 28, one night's 76, their AHI. So important thing here is like we want to measure multiple nights if possible. It's not always doable, you know, but we know night to night variation, especially with patients that are mild. We may not get it every night. So multiple nights is important because we're going to see, as in this case, in one night it's actually moderate, the next night it's severe. Um, Severe OSA above 30 here, of course, we're getting that, but you can see even like the O2 sats are dropping in the 70s. The pulse is dropping in the 40s. I mean, that's normal at some point, but you want to make sure that it's not due to a bradyarrhythmia. You can see the O2 sats are really falling down low during those times of peak events that they're having throughout the night. So this is a patient that's severe OSA, another severe OSA here, patients that have, here's a patient that has um, an AHI 56.4 or 65.5 when it comes to 3%. And then their O2 sats are falling down to 73%. So one point here is that you got patients that'll come and present with severe OSA, and of course, we want to, especially if they're desatting quite a bit, CPAP still is the gold standard for that, right? You may have patients that have already failed CPAP. Ask that question. Number one, they've been diagnosed before, they've failed CPAP. And, in terms of that, the next line is oral appliance therapy. Okay. And I've seen it work for patients that have severe OSA, right? So, but you got to get that clinical history. Now, if they haven't failed CPAP before, sometimes the payer is actually going to make them use CPAP and fail it, right? So sometimes they got to go through that process. Sometimes they're going to tell you like they refuse it. Okay. And if they refuse it, document that, right? And guess what? Some therapy is better than none, right? So we want to get that apnea treated as best as possible. And again, like I've seen patients that have severe OSA that respond to oral appliance therapy. Not everyone, but we want to make that effort at least in getting that down and then making an assessment like, where are they? And some patients even respond to combination therapy, right? So they might need CPAP and oral appliance therapy to get that under control. Maybe they can't tolerate higher pressures of CPAP, and the combination makes a big difference. So again, that's where you got to go beyond, the AHI and really think clinically in a lot of these folks. I mentioned this earlier, severe OSA and mild CSA. If you see central sleep apnea, we made that diagnosis if it's in the mild range, but the OSA is the primary diagnosis, don't freak out, right? It's a very common thing. You can still treat the OSA, right? A lot of times the CSA will get better. Okay. So where you really got to consider an in-lab study, ASV, BiPAP ST, that kind of thing, is patients that have primary central sleep apnea and it's severe, right? And those are the ones that we really need to put into the lab or get a better assessment in terms of treatment. We're not going to treat those folks with oral appliance therapy. It's not going to work. But in this sort of case, don't freak out. It's okay. It's normal. It's common, in fact, because what happens is the O2 desats cause the CO2 levels to rise or to stay low as well. And then what happens is your brain just says stop breathing to get that CO2 back to normal. Okay. So it's a blood gas exchange issue. This is severe OSA, moderate CSA, CSR, Cheyne-Stokes respirations, right? So here's a patient, right? They have moderate central sleep apnea. They're having some Cheyne-Stokes respirations. So could this be a patient that benefits from an in-lab titration? Yeah, if they don't want to do it, you could always still treat the OSA using the oral appliance and then retest them and see where they're at. Okay. And then decide, do you want to add CPAP on top of that? Do they still need a titration? That's really an important thing clinically, is get that, get that patient to comply with some treatment. And then at that point, you can reassess them. And reassessing is very important. I know a lot of dental colleagues don't do that enough. And I can't say that how important that is, that once you start a therapy, continue to reassess your patient and get a better idea of where they're at. Because you'll be surprised how many patients may respond, right away to your first line therapy. But even if they don't, they've got improvement, and now we can add other therapies on board. Hypoxemia is a no-brainer. Someone that's desatting to this degree, look at his AHI, 148, okay? And average oxygen saturation is 82%, okay? Minimum is 67%, right? They're spending tons of time below 88%, which is kind of the Medicare marker of hypoxemia. And we know it's beyond just the AHI. And so this patient should really have a lab study, right? So if we make the diagnosis sleep-related hypoxemia, we urge having a lab study done where we can titrate oxygen as well. You're going to have patients that refuse. If you have that, that means that they should see us, or if they get started on treatment, you got to measure their O2 while they're on treatment. Okay. And that it's obviously more complicated, but you're going to have patients that may refuse that. You want to go one step further. We talked about this slide earlier. So I'll end with that. Okay. Open up to any questions. I mean, of course, this is our gold standard, sleeping like a baby, right? But, the older we get, we know it's harder, and we just want our patients to be able to feel restored, and really feel that sense of vitality, which is a natural human phenomenon, right? That's our goal. And whatever we can do to help them get there, that's what we want to do.
Yep.
Yeah. You want to talk about this, Michael? Or
yeah, you know what? Let's go ahead and do this first, and we'll get into questions just from a time standpoint.
Yeah.
So first off, that was phenomenal. Second, I just want to ask everybody in the audience, because we can't see your face, show of hands, who's thankful that we get to treat the easy folks instead of the complex cases that have multiple types of apneas that we're dealing with multiple therapies and constant monitoring. Yeah, Dr. Singh, we're thankful for people like you that want to take the hard cases. So we'll get back to testing. We do have questions. Let me explain the slide real quick. For those of you that haven't heard, we have our Pivot Dental Sleep Medicine Masterclass coming up. It's a live event that Awaken to Sleep is hosting in San Diego in September 20th and 21st. If you guys want to know more about the business side of DSM, how people like Dr. Kent Smith, Dr. Stacy Lehman, Licia Crawford, folks like that are crushing it in your industry, come to the course. It's strictly business. We're to sit down for a day and a half. It's workshop style. There's 25 doctors as far as attendee slots for doctors that are available, and we're about half full. So if you guys want to come, we'd invite you out to that. We're going to do a lot of stuff to work on your plan. Doc, if you want to go to the next slide, I think we've got a team member video.
Lawson. I am sleep champion at AHI Family Dental. We have worked on sleep for a long time in our practice, but we could never figure out those little systems and setting goals to really make it a difference. Working with Mike and Chad at Awaken to Sleep really has opened our mind and our practice to getting those systems in there and working with more patients. My favorite thing about the Pivot DSM Masterclass this weekend has been connecting with other offices that do the same thing that we do. It's a unique thing in the dental world to practice dental sleep medicine. So getting to know their systems, telling them about our systems, getting to learn from others, your peers doing the same thing that you're doing in your office is fantastic.
She's very kind. Can you go to the last one? If you guys are interested, there we go. QR codes for both. You can talk to somebody at our company for free. You guys know that if you've been here. And if you are interested in the masterclass, you can put your phone to the screen. It'll take you there. Yeah, I mean, we're going to hang out. And it's San Diego in September at the #3 resort in San Diego with a private beach that we're having lunch on. Like, that's not the only reason to come, but it's kind of one of the reasons to come. And
yeah,
Dr. Singh's going to be there.
I'll vouch for that. I'll vouch for that. I was there last year, and it's amazing. Beautiful venue.
Yeah.
Absolutely.
Yeah. And you're speaking on
Right.
the sleep physician side, the perspective on the MD side when dentists come and market to you all and effective measures to do that. So yeah, we're going to have some fun there. So yeah, if you guys are interested, you've got questions, email us or, schedule a call with a coach. If you're just ready to go to San Diego, there's your link. Speaking of that, let's get into our questions. James Mikowski asked, why aren't the EMGs attached to the masseter muscles? in an HST. Doc, just confirm that on the HSTs that do run EMGs, we're attaching to the pit bull muscles right here, correct?
Yeah, so there are not a lot that do, but the ones that do, correct. That's where we attach them, right? So you can still get a flavor for you can still get a flavor for bruxism and clenching even there, honestly. So but there's not a lot that do that, right?
Yeah, absolutely. Another one, we're going rapid fire here. 3% versus 4%. You did address this. Let me take this just for time's sake. You want to measure apples to apples, folks. If you've got a diagnostic HST PSG that's running on a 3%, you absolutely want to run your HST on a 3%. If you're running the diagnostic test, like Dr. Singh mentioned, that's read by a sleep physician and diagnosed, that has to meet the payer criteria. Medicare's 4%. Make sure you understand the payer criteria if you're billing medical for that. Did I say anything wrong there?
100%.
Sweet.
Yep.
Okay. Barry Glassman, the man, the myth, he says, discussion of the problems using AHI in terms of severity comes from a long discussion of the length of events. Absolutely right. Length of events, hypoxic burden. How bad is this really? How many times an hour doesn't really tell the story. When you go past the twice a minute at 120 something events an hour, and then you start retreating back to lower numbers with longer apneas, higher hypoxic burden, all the stuff.
Yeah.
Jesse asked, what do you think about insomnia being their chief complaint on a screener form? And her personal situation. She's young, fit, and suffered from insomnia for years, got tested. She's moderate AHI of 19.
Treat the AHI, treat the apnea, because they're going to come in with that primary complaint, and apnea trumps insomnia. The only place that I would say where you got to be a little bit more careful, where you might need some help in terms of another colleague like us, helping you, is if a patient does get on treatment and their insomnia kind of worsens, it could be that they're so cognizant of that treatment, right? So maybe we got to add a little bit of melatonin or something on top of that. But always treat the apnea first, and a lot of times you'll find the insomnia gets better.
Yep, on point. Treat the known factor, Jesse, and then when that's resolved, you start moving one at a time. You can't treat the whole puzzle all at once. Okay. Yeah, awesome. She said she's using an oral appliance and the insomnia went away. So insomnia was secondary, friend. Thanks for asking a good question. Prita says, with the new HST technology, it's being recommended to use it 3 to 4 times in a week with the patient, and then get an average of the values as opposed to olden times. One night testing. Feels a little loaded, Frida. Doc, thoughts, candid thoughts.
Yeah.
Just tell us what you think.
Yeah. So, I mean, in a perfect world, that is probably the better way to go in terms of getting an average, right? But, we don't have systems right now that can do that. So in terms of the sleep doc, like myself, that's looking at all that data, right? That takes a lot of work in terms of coming up with an average. So what we tend to do is we have 3 criteria, right? When we're deciding which night to go with. So signal quality has got to be good. Total sleep time has got to be enough. And then we're going to go with, okay, what seems like the patient's got the most significant apnea during that night, right? So if a couple of nights are negative and one night shows positive, we're going to go with that, making that distinction. But, again, this is where we're sort of, I think we're going to see changes in the next 5 years or so, right? In terms of coming up with better ways of figuring that out.
Yep. Yeah. On point. If we could get all the data we wanted from every patient, we wouldn't have home testing, because everybody do a few nights in the lab and we get great data on everybody.
Right.
We'll take what we can get and go with what we got, because we're going to help folks as much as we can. Yeah. Love it. Doc, I appreciate you a bunch. For those of you that don't know and didn't see it in the chat, you have your CE link, you have your masterclass link, and you also, we have back-to-back webinars tonight, folks. Just in case you didn't get both emails from both companies, Dr. Singh is going to a panel webinar about the AADSM updates with Transform Dental Sleep. So we went ahead and put the link in there as well. If you guys haven't registered for that, you should do a back-to-back with Dr. Singh, because then you can say you have, and it's going to be worth it. But for the sake of time, Aman, appreciate you, man.
Hey.
Genuinely appreciate all the wisdom that you brought tonight and spending the hour with our audience here. Thank you.
Yeah. Thanks for having me.
Yeah.
Great. Yeah. All right.
All right. Have a good night, guys.
episode.
We'll see
Yep.
you on the next webinar here.
Thanks.
All right.